And let me share my screen. There we go. Can you guys actually see my screen, or you see the presenter screen?
We can see your slides.
Okay, perfect. Thank you. All right, so mechanical valve thrombosis, making the diagnosis, and just hopefully I can transmit to you some things, some learning points, and some things that are worth noting. And what I really wanted to make sure is that really this was not meant to be an exhaustive analysis of the evidence of how to best make a diagnosis, but some practical tips and really some perspective on the diagnosis and the treatment of a pretty critical condition. With all due further ado, I think all of you probably understand and sort of have an idea of the differences between mechanical and bioprosthetic valve, but these are, for example, the types of bioprosthesis and mechanical valves you would see. And for us as surgeons, we certainly have seen them closely and we sort of understand quite well how they are. If you were to look at this one here, this is a bileaflet mechanical valve. It's probably the most common mechanical valve you would see. These were very common at some point. They're the old Bjork-Schally, and this is a Med Hall. It's a single leaflet or disc as a large orifice and a small orifice. These very rarely in your life you're going to see. These are the old ball valve, Edwards valve, and then the bioprosthetic valve. This is a porcine bioprosthetic valve. This is a pericardial prosthetic valve. This is an actually porcine root, and these are transcatheter valve. You have a balloon expandable valve, that's a sapien valve, and a self-expanding valve. This is a Medtronic core valve or Evolute. So each of those valves have particular features that make or may not lead to issues or problems, and they're important sometimes to consider, and hopefully I can highlight a little bit of those things. So what are the trends in how we see bioprosthetic valve or mechanical valves in the surgical world? Well, you can see that there was a time, and here this looks at over the years from the 1990s to almost 2020, the trend in red, which were mainly mechanical valves, get gradually smaller. And this has been a consistent trend to the point where currently less than 5% of all aortic valve prosthesis are mechanical prosthesis. And I worked in a center before, and I was trained in somewhere where bioprosthetic valve were largely used. It's exceedingly rare that we use a mechanical valve for a variety of reasons. And I don't want to make it today's talk, but it is just a reality. But mechanical valves still exist, and they were put in many years ago and are still around and potentially lead to some problems. So mechanical valves are generally considered to last longer than biological valves, but we should not be under the impression that they last forever and they will never fail, which is sometimes the way surgeons or even physicians would think about them. Oh, you put a mechanical valve, you never have to worry about it, never need to operate on them. The reality is they are still prone to failure. It's just the mode of failure will be different than a bioprosthetic valve. So bileaflet mechanical valves are the most common, and I think it's worth noting how they're designed. They're basically these leaflets that are held into hinge points that are here, and these little hinge points are really the place where thrombus or anything could accumulate to lead to a malfunction. And you can have malfunction of one of the leaflets or both leaflets, and you can see it's contained in a housing. And the housing is there to prevent tissue growth from the outside in to try to protect the leaflets. But the tissue growth can still occur above or below. And below in particular, where the leaflets are at the side here or even above, can lead to some impingement of those leaflets. We call that pannus. So these are the types of things that can happen to these valves. You can imagine you can have thrombus formation either at the hinge point or on the leaflets. That would lead to malfunction of the leaflets. Endocarditis can occur when there is things around that it can actually impede on the inside. And pannus growth is really tissue growth that leads to problems. And that's sometimes very difficult to identify or to prove, but obviously cannot be dealt with by other means than with surgery potentially. So the patient story. So I thought I'd illustrate a patient and then just go through some investigations and the things that we've done to sort of try to get us there, and it will illustrate many of the points I want to make. So So a mid-60s person, worsening shortness of breath over weeks, but really particularly bad over a 2-week period. Past medical history had a previous coronary vascularization and aortic valve replacement many years ago, let's say around 10 years or so. I don't want to be too specific, obviously. And a St. John mechanical valve, 21 was what was in place. So small aortic prosthesis, 19 being the smallest. COPD, so significant lung disease, asthma history, quote unquote, good INR control. So based on the evidence or the questions that we would ask that patient is they had reasonable INR control. And clinically, however, they're functional class 3 to 4, so really short of breath even at rest. And valve sounds, and not having a reference of what they used to sound, which is really what's helpful in these patients, appear to be at times potentially reasonable or reasonably crisp. So this is the first echo that was done, or one of the echoes that was done in that patient. And you can see that there are clear increased gradients on the valve. You can see the velocities are above 4 meters per second, aortic maximal gradient, in the 80s. And the point that I want to make here is obviously increased gradient that are changed from before. So if this was a small prosthesis and always have seen high velocities, it is conceivable that this is not a change, but this was clearly a change. Mean gradients were in the 20s before. Now the mean gradients in the 40s to 50s. So they were clearly doubling or tripling of those. EF was poor and mild to moderate aortic insufficiency. And the aortic insufficiency did not appear to have the typical sort of washing jet that you might have, because all these valves are designed to allow some insufficiency to wash those hinges points that I've mentioned before. And I think, 8 to 12 different jets can be actually described in these patients. So if you were to look at the echo, this is the original transthoracic study. And those for you who are not used to looking at echoes, basically you're looking at a pretty significantly, depressed ejection fraction, a mitral valve that's obviously moving reasonably. And you can see on the other view here, a jet of aortic insufficiency that is, there should be another jet the other way. They tend to be symmetrical on both sides. There's something a little funny here that, having said that, I'm only showing you one view, but it's a bit funny to have in a bileaflet valve an abnormal jet of insufficiency that's more on one side than the other side. So it makes you worry that there's something not quite right here. So how do we make the diagnosis? So while there may be suspicion here that one of the leaflets is not working perfectly or there's an issue, there's obviously concerns on how you make the diagnosis, because the treatment would be really important in how you proceed. So making the diagnosis, the standard approach, tend to be, ruling out endocarditis, which was done, transthoracic study, which was done, obviously suggesting higher gradient. Do you do a TE? Do you go to fluoroscopy? And the risk factors here that I think are important are to consider always is small prosthesis, a little bit higher risk, obviously. Aortic position is less of a risk than mitral position, and the poor INR control, which was not the case here. So there's a few aspects here that suggest that this patient didn't have all the risk factor other than a small prosthesis. If we were in an audience, I'd be asking people what they would do, but anyways, we're not really in an audience, a bit too hard to do that. Whoops, if I can change my next slide, maybe it doesn't want to go. Oh, there we go. So they came for cardiac cath, and it's one of those things, if you don't focus, it depends what you're looking at. If you're looking at the angiogram, this is a bunch of vessels there. That's really not what I want you to focus on. I want you to focus on the valve itself. And you may or may not notice that there's one leaflet that I see the entire time. Well, that leaflet should be like the other side. It should be moving. And because of the frame rate of the angiogram, I should not be seeing those leaflets. So clearly something's not right here. That leaflet appears stuck in that position. So did we make a diagnosis here or not? I guess we can debate that. That wasn't the point. It's just showing you that ancillary to what we're looking for here in the angiogram is what we saw there. So if you undergo transesophageal echo, these are two good images for transesophageal echo. I should be seeing two leaflets, and this is so there's a 3D image here on the left and a non-3D image on the right, both showing essentially the same thing. there's really only one leaflet that I can demonstrate moving. So transesophageal echo, and these were taking intraoperatively. So I'm already telling you what we ended up doing. But a transesophageal echo would have been helpful potentially in helping. But sometimes the views are difficult, and it's hard to tell, and you're not certain. You get lots of shadowing, as you can see, of the shadowing of the valve itself. So T echo is difficult sometimes. So what about CT scan? And CT scan, as it turns out, I'll show you the images, was impressive to me in terms of helping making that diagnosis, because fluoroscopy, as I showed you in the Cath lab, sometimes is ambiguous and not that easy to see. It was only one of those images that we were able to see that leaflet now move perfectly. Transesophageal echo can also be challenging at times. And here I'll show you the video of sort of reconstruction of that CT scan. Of note, you can see here, for those of you who don't look at these very often, you can see the bone and there's a non-union of a sternum. So if you were to examine the patient, you would have seen their heart was beating in between. You could see or feel that heart, just there was a big gap in between here. So it's a chronic non-union. Let's see what the video shows. So it takes a few minutes to go through. You'll see here previous graphs here going to the lima to the LAD, and you see the ventricle contracting, and so you'll see in a second plunging into, and these are Terra Recon reconstruction from RCT imaging, which is outstanding and pretty amazing. You can see ventricular function is not very good, quite dilated, and you can see here a leaflet moving. It's hard to tell, is there two leaflet moving, but you'll see much better in a second once the orientation is done. There's really one leaflet here that's fixed, and there's one leaflet that's moving beautifully. And you'll see some black underneath the valve under, these are probably thrombus. So there's a lack of contrast going around that. And here's looking en face, again at that valve, you'll see one leaflet moving beautifully and one leaflet that's stuck. It actually is almost vibrating a little bit. You can see it just move a tiny bit. And again, a view from underneath, which is again, super nice in seeing the valve leaflet move and not move. So just to point out that, in my mind, the CT scan here was unequivocal of what the diagnosis was even able to show thrombus, as you can see my little arrow here. And this is care of, obviously I don't do the CT scan, our CT scan a radiologist here, Dr. Brian Archer, facilitated this and was able to demonstrate this quite clearly. And again, the leaflet's moving. So CT scan, in my mind, I would never not consider that as a way to help us make that diagnosis with Terra Recon reconstruction after to do that. And these are cardiac CTs. So what's the management approach in this setting? So we've made the diagnosis now, and unfortunately that diagnosis took several days, if not week more to make. And it's really about balancing the risk. You're trying to evaluate reoperation versus thromboembolic and in the thrombolytic type world, or bleeding complications associated with thrombolytics. And there's been a lot of debate over time. There's still controversy, and you can find certainly evidence supportive of both approaches. But recent reviews, and here are some of the things that are probably worth considering. And the treatment of prostatic valve thrombosis is described. This is published in just a few years ago as thrombolytic therapy appears to have reached a little bit more of a standard in terms of approach initially in these patients. But what's important here is obviously separating between right-sided prostatic valve thrombosis versus left. And if you have left, whether it's obstructive or non-obstructive. And in this setting, we felt that, or I felt that it was more on the obstructive side. Having said that, if you look carefully on all of the transthoracic studies, there was variability in terms of the aortic insufficiency. So it might have at times not been, it might have been more open than closed setting. So clearly in an obstructive setting, consideration should be made for thrombolytics as a first therapy. And again, it's really trying to balance the risk. And here the risk for her was around Euroscore risk. We estimated, 30 to 50% mortality risk based on reoperation, patent grafts, low EF, calcified aorta, and some parts of it with calcified arch, high New York Heart Association, pulmonary hypertension, sternal non-union, and those type of things. And how do you balance the risk of thrombolytics? Only thrombolytics is not without risk. The risk of bleeding and or emboli may be as high as 10 to 15%. So again, balancing those things. So what did we end up doing? So, before I say that, so obviously controversial. So this is some of the summary of that review paper. Mortality for surgery is very variable depending on the patient, and their New York Heart Association can be between 4 and 60%. So obviously very broad. It really depends on much of the gestalt of how the patient is clinically. And also to consider is what's your likelihood of complete resolution of the problem. So with surgery, obviously the resolution of the problem should be higher or closer to 100%. It obviously not always is. And with thrombolytics, surprisingly, hemodynamic resolution can be as high as 70% depending on the series. So obviously in selected patients, it can be used and result in a successful and lasting benefit. But again, the difference would be whether there's truly thrombus there, whether it's pannus growth or not, or a combination of the two. And this is really important. So the course in the hospital for us was admission, obviously, for peripheral hospital, so difficult to send here, and getting, so that's always a challenge, I'm sure, from all of you who refer patients in really sorting out the best approach for these patients. So multiple investigations, transthoracic, transesophageal, angiogram, CT. In my mind, most definitive was a CT scan, and perhaps we should consider doing that as a first avenue when we're uncertain. Therapy, anticoagulation was obviously obvious with heparin here, but thrombolytics was tried here on 2 24-hour period. And that resulted in pretty significant improvement in how she felt. So New York Heart Association got better, her heart failure got better, her wheeziness went away, she felt good, almost to the point where it made me think that, I wonder if the last few months where she was feeling short of breath, she actually had a leaflet that wasn't working perfectly, but the other one was working well. But we clearly did not see complete resolution. There was still one leaflet that wasn't working well. And I felt that the risk of leaving that alone, not knowing what would happen to that other leaflet, it was too high, and therefore surgery was indicated. And this is what we found at surgery. And it's worth noting, if you look at the valve here, sorry, there's lots of stuff around it, but this is the stuff that gets caught in the hinge point. And it really looks like tissue rather than clot. So it's really well-formed clot. And I tried to pick at it with a forceps. I could barely move it. This is on one side, and you can see on the other side. So clearly that leaflet was very hard to move. And you can see how close it is to the other hinge point. So that other leaflet is clearly at risk over time. So while one leaflet may work, the other one doesn't, you're okay in that moment, but are you going to be okay for a long period of time is obviously not necessarily the case. So the course in the hospital for surgery, she's done remarkably well, and hopefully we'll be going home the next day or two as we're managing her heart failure. So clearly this was the right choice, but the course was certainly long for that patient, and making diagnosis is not always easy. So in summary, I think mechanical prostheses are less common, but are still prone to failure, and we need to still have a very high index of suspicion when these things happen, and decision-making is not always easy. So clinical suspicion is key. Definitive diagnosis is not always easy, but I think CT should be something that should be considered. And can any CT be done anywhere and allow reconstruction on anterior recon? I am not a CT expert or a person that reconstructs these images, but having the raw data is critical. And not every place in the province, for example, collects or keeps all of the raw data and the amount of storage required for that. So they tend to come here for this, and I cannot speak to that, whether that can be done elsewhere or reconstructed in that manner elsewhere. And the treatment remains controversial, and obviously a balance of risk and benefit between thrombolytics and surgery. And thank you. So I was going to stop share here and open to questions.
JF, can I ask a question?
Yes.
Yeah. In your review, did you learn anything about how often bileaflet valves, just one leaflet thromboses? Because in the engineering of mechanical valves, that was always mentioned as an advantage of a bileaflet over the initial mechanical valves when they went to a leaflet design were uni-leaflets or a single leaflet.
Yeah.
And the second question for the audience, or education of the audience would be the inability of NOACs to anticoagulate, at least a current generation of NOACs to anticoagulate mechanical valves.
Yes. I echo your second point. Your first point, I don't know the answer. Having said that, anecdotally, I have in the last few years seen a patient that I followed for quite some time, over a year after I'd seen him or met him. He was a gentleman with a pretty large aortic mechanical valve in the setting of having had, unfortunately, a pneumonectomy after that with an FEV1 that was very low, and had a routine echo done and only one leaflet was moving, ended up here to come for assessment. And in the end, I made the decision to never treat that leaflet that was blocked because, one, he was asymptomatic from it, two, would not tolerate an operation, and this was a chronic problem. So clearly, I think you're correct that there is potentially an advantage of having a bileaflet valve from that point of view. He was just lucky that it was completely closed shut and never moved, while the other one was moving perfectly and was, in the big picture, the right management for him. But I argued in this setting, given the small prosthesis, that I was worried that it was going to lead to problem if I left it alone. So it's a little bit anecdotal.
Sure.
So there's a question from the audience.
And about the NOACs?
Yeah, the NOACs and DOAC is a no, a strong no at the present time. And having said that, there are newer generations that I believe there are some trials or some discussions around those things. So I cannot speak to the future, but in the present, they're really, we used vitamin K dependent sort of warfarin as the management, and obviously heparin as a management when they're in a hospital for anticoagulation. That is the treatment.
There's
Thanks.
a ongoing trial for Onyx with aspirin DOAC, though the results I don't think have been published yet.
So there's a question from the audience. I'm just going to read it. Thank you for the informative, thought-provoking presentation. That's good. How do you phrase the question to ask the patient in lay terms about their INR control? Oh, very good question. How long do prosthetic valves generally last? Does always experience characters? So the first part of the question is, is the best way is really to look at the documented rather than asking the patients, because the reality is, even in the best of scenarios for INR control, I believe that the 30 to 40% of the time patients are out of range, and that's a best scenario. So clearly we need to assume that most patients are not in range all the time. The question is, are they more on the thrombotic or the bleeding side, and are they for extended period of time? Generally speaking, I think of the aortic valve as not a place where the risk is that high. So I tend not to worry that much, but clearly I'm wrong, as this particular case was aortic valve. Aortic valve can last decades and decades or lifelong in theory. And the characteristic symptoms can be insidious. And that's why I wondered in this particular patient if the shortness of breath that had been probably for months had actually been insidious with one of the leaflets not working properly for a long period of time. And eventually what got them into trouble was completely getting stuck. So the findings can be a little more insidious than one thinks. And obviously the demonstration then becomes a little more difficult. Yeah. Any other questions?
JF, do you worry more about thrombolytics not working, whether the valve is early versus late implantation? Do you think there's a difference there?
Yeah, there probably is. I think the problem of the evidence is it's a mixed bag of patients. I think the early, most people would believe that perhaps there is, but I think the early is more around early symptoms rather than early valve. So, and that's always the hard one. I think if the symptoms are relatively acute, patients really sick, I think thrombolytics make a huge amount of sense to try, because you may get resolution improvement in that patient. But having said that, I've in my lifetime gone through both ways, and I'm not sure still of what the best approach is. I've certainly seen patients get dramatically better, and I've seen patients not do well at all, and both ways with surgery also. I think here, this was a relatively more chronic, I think, nature rather than acute. So it was acute on chronic.
Yeah, JF, I'd just echo your thoughts that most likely this lady's leaflet was starting to become immobile and then eventually became completely immobile over several months.
Yeah, I would think so.
And that's always been talked about with bileaflet valves, as opposed to the acute emergency of a single leaflet valve. Doesn't take much to imagine when that thrombose is usually in a semi-open, semi-closed position.
You're
Patient
done.
goes into acute heart failure, and
And
more
shock.
often than not, you have to operate. You don't even have time for thrombolytics to go. You got to go straight to the OR once the diagnosis is made.
Yeah, I would agree.
Yeah.
Okay, so for everybody, consider CT scan. And that's not something you're necessarily going to see in the guidelines or the recommendations. I was very impressed. I mean, that imaging was, and that's part of the reason.
The best imaging I've ever seen for a thrombose leaflet. Wow, like I would agree. Put CT right up there at the top.
Yep, I would agree. So it's changed my life. So there you go. I will never do anything different. All right. I'm sorry for the CT people. Thank you, everybody. Have a good day.
Thank you.
Thank you.